This is an issue, type 1 diabetes and obesity, that's now taking a new role in the management of the disease, because many patients with type 1 diabetes are now become obese. And indeed, type 1 diabetes was never associated with obesity. Until recently, the picture, the phenotype, so the appearance of the patient differed, because patients tend to have a body weight that is not the typical body weight of a type 1 diabetic patient, lean, usually without insulin. Now, because patients are on a pump and are on a glucose monitoring, they eat as much as they want because they have the insulin release automatically by the glucometer. Okay. Therefore, the body weight increase is due to an increase of insulin that the patient take. Okay. So that, I think, is a novelty. And from one side, make the patient living better. They actually don't suffer for hypoglycemia because there is the continuous glucose monitoring that control the pump. And so everything seems to be perfect. But the fact that they eat more and they take more insulin, they put on weight.
Exactly.
So this is a new phenotype that has never been seen before. Is the technology that induced this new phenotype of obese people with type 1 diabetes. And of course, that poses a lot of questions, in particular because you have complications associated with type 1 and complications associated with type 2 in the same individual. Before, the complication of type 1 diabetes that we, of course, try to prevent are retinopathy, nephropathy, and neuropathy. Now here we have definitely a new type of features of complication characterized by the presence of cardiovascular risk. So the cardiovascular risk due to macrovascular disease, it is a new thinking for patients with type 1, because it was typical for patients with type 2 diabetes, but not for patients with type 1. So that poses serious concern in terms of treatment. And therefore, what we find now, that there are these new drugs, the GLP-1RA, that have been approved in the US, but not in the rest of the world, for treatment for type 1 diabetic patients. So there are still discussion about approval of the GLP-1RA for treatment of patients with type 1. But this emergency is that patients need to lose weight, because if they don't lose weight, they are at increased risk of cardiovascular complication as well. Exactly. So I think that the new paradigm for patients with type 1 diabetes today, with this new technology, they make life easier, better quality of life, because they don't really suffer anymore of hyper and hypo, thanks to the pump, has created this new problem. So we're facing a new situation that we have the possibility to treat well with drugs available, but we need to apply the treatment properly and according to regulations. It depends on the process of beta cell destruction. The immune process is at the beginning of the disease, because at the beginning of the disease, there is the autoimmune process that is typical of type 1 diabetes. But if you are overweight already, because you have the wrong diet, you increase the autoimmune process leading to beta cell destruction. So you lose more beta cells and you will need more insulin then. So it is important to avoid overweight and obesity in people that are at risk for type 1 diabetes. And I think people at risk for type 1 diabetes are the first degree relatives of people with type 1 diabetes that are unaffected. And I think this is something to keep in mind, that obesity can stimulate further the autoimmune process leading to beta cell destruction and the onset of type 1 diabetes. I've been involved in immunotherapy of diabetes since the first trial in the world with cyclosporine.
Wow.
That was in the late 80s.
Oh, a long
and
time.
That was my first trial, and was an international trial. And then many other trials have been carried out, originally with cyclosporine. That was the first drug that opened the field for type 1 diabetes immunotherapy. So 40 years of immunotherapy have failed to find a beneficial effect of immune intervention. All different types of drugs have been tested, different processes have been tested, and they were not efficient in terms of protecting the residual beta cell function, or maybe stimulate residual beta cell function to restore some of their function. So the point is that more recently, monoclonal antibody have been used, some monoclonal antibody have been used, and one monoclonal antibody in particular, the anti-CD3, has been tested, and now not only newly diagnosed, but also in patients that are at risk of developing type 1 diabetes. So this population of subjects that are first-degree relatives of type 1 diabetic probans represent an ideal population where you can treat with anti-CD3 monoclonal antibody, and maybe with combination antibodies if other antibodies become available, tackling different processes of the process, the immune process that leads to beta cell destruction. Because the process that leads to beta cell destruction is wide. There are not a single mechanism, but more than one mechanism is responsible for the damage to the beta cells. At the moment, the use of anti-CD3 seems promising because it delays progression towards the onset of diabetes. And you may say, well, but if you delay the onset, you will still have diabetes. Yes, you still may be having diabetes, but if you intervene earlier, you can keep more beta cell function left, endogenous beta cell function left. And if you keep more beta cell function left, as been demonstrated, you actually are predisposed to remain free of complications or long-term complications. The C-peptide is the marker for a beta cell function, residual beta cell function. And the data in patients with 50 years of type 1 diabetes, where the C-peptide has been measured, have found that those that have C-peptide left have less complications. Less retinopathy, less neuropathy.
Good.
So that is what we are aiming for, is not completely off insulin, but reducing the amount of insulin and having some beta cell protection left. Now, the patient stratification, first of all, we have to think that type 1 diabetes is very heterogeneous. You may have an onset in a very young age, under the age of 10, prepubertal, pubertal, during puberty, or in young adult, or even in adults up to the age of 50, 60, the so-called LADA. So basically, we have 4 different age of onset of type 1 diabetes. And this different for age of onset implies that the treatment may vary according to the age of onset. Because if you think for a moment, LADA, so those patients that have an autoimmune diabetes at the age of 40, 50. These patients are basically type 2s, but they have an autoimmune process ongoing, so they are type 1. But in this patient, all immune intervention trial and other intervention have been shown to be satisfactory, at least in terms of protecting the C-peptide that I mentioned before. And protecting the C-peptide, you avoid developmental complications. So if you intervene late, in late age, you have better chances to obtain good results with immune intervention. It's a difficult question because there are different options here. One is the genetic manipulation and things that are under phase 1 trial, so really not behind the corner to be used, but definitely are of interest. And this type of treatment try to modify the disease process in the very early stages. So we're talking about very young people where there are antibodies, and then when we intervene, when still the process of beta cell destruction is ongoing, but is in the very early phases. Now, artificial intelligence, I think it could be a useful, and it is a useful tool, basically because type 1 diabetes is very heterogeneous. And so if you ask artificial intelligence to help you in defining the phenotype and the genotype of patient you want to treat, and what is the best treatment for that particular genotype, phenotype, you could actually have some good inspiration of what could be the best treatment for that patient. So from a clinical point of view, I think is helpful. And also from an experimental point of view is helpful, because the question that the clinician or the researcher asks to AI vary according to their demand. And I think both can take advantage of AI. Depends which AI program you're going to use. There are so many, and there are some good ones for scientists that have more information, in particular with references to, because there are millions of references. Every investigator like to see references to think more, rather than say what artificial intelligence says without giving reference of the work. I think this is the secret. Having references with you, and then you can think and take great advantage for your research.